All right, we're here at the AATS Mitral Conclave 2017, and I'm thrilled to be joined by Dr. Joe Chikwe. Joe, good to see you.
Good to see you, Randy.
So you just had the pleasure of moderating a debate or discussion about when do you do repair of functional TR with what I said are 4 non-consenting adults. But so what did you take away? What did we learn? When to repair functional TR?
Oh, we learned a huge amount. There's this vast spectrum of approach to the tricuspid valve. And I think we know 3 things. We know that it's safe to do concomitant tricuspid valve repair. I mean, you have some of the surgeons with the largest experience in mitral valve repair, and they're not seeing increased complications. You know, you hear about disasters like the coronary arteries being damaged or pacemakers, but less than 1%, 2%, and it's the same for patients that don't have tricuspid valves. But more importantly, so we know it's safe. More importantly, we know that these rare outpoints, severe TR, need to come back to the operating room to repair or replace that tricuspid valve repair. Those are really rare. So the proponents of leaving the valve alone, they tend to use those endpoints to justify a conservative strategy. What we do know from our experience is early on what you see is better right ventricular modeling. If you tackle the tricuspid valve in these patients, we know that your pulmonary artery pressures will come down. We know that your right ventricle will look better on an echo. And what we want to see is how that translates in the long term. So my take home from today was repairing the tricuspid valve is safe. It's probably going to reduce those long-term late severe endpoints. And for the vast majority of patients, it's going to restore their right ventricle to a better status.
So that's, I mean, I think that's a valid argument. It's something I happen to agree with. But, what about Tyrone's standpoint that he's followed patients after mitral valve repair forever and very few people have TR? I mean, it's not what I'm seeing in practice.
I think Tyrone's series is a great example of what fantastic mitral valve surgery should look like. And clearly his cardiologists and his echocardiographers have focused very well on looking at the left ventricle and looking at the mitral valve. But he says himself in his manuscript, and he'll say it multiple times, those echocardiographers were not interested in looking at the right side of the heart. He literally says it was overlooked for a long chunk of that series. So I don't think we genuinely know, firstly, what the prevalence of tricuspid regurgitation was at baseline in those patients, and I don't really think we're seeing the true numbers of patients that had significant tricuspid valve disease after surgery.
Joe, what about AFib as an etiology of TR? I mean, I think, in fact, I think a lot of the TR patients are, either in the EP centers or in the heart failure centers. Is AFib, chronic AFib, a risk factor for developing functional TR?
So atrial fibrillation is probably one of the most important risk factors, and we're not talking about valves in isolation here. We're talking about atrial fibrillation, pulmonary artery hypertension, right ventricular dysfunction and dilatation. You have any of those, you have to think aggressively about fixing that valve prophylactically.
Okay. And 2 other questions. Do older women, are they more prone to develop TR? Do we know that?
We don't know that.
Okay.
We may suspect it, but we didn't have quite the numbers to show that conclusively.
And is the 4-centimeter measurement of the tricuspid annulus the holy grail?
It's not the holy grail simply because there's so much inter-observer variability, one.
Tremendous.
And 2, we all know that you have a small body surface area patient and a large one. The annulus are different. It's probably the key thing for us as a group was the direct assessment. So if there was any question on that preoperative echo in terms of the diameter or the grade of TR, just open up the right atrium, compare that septal leaflet to the orifice if there's a mismatch. That's probably your holy grail of whether that patient needs an annuloplasty.
So take a look at that.
Take a look at the valve.
A look at it.
It's a freebie.
Are there people that you would not do a tricuspid repair on when you're doing a mitral repair?
It's a question that gets asked, and oftentimes the assumption is that the sicker patient, that elderly lady that you spoke about, or the patient with the RV dysfunction, it's all about trying to minimize the time on bypass. I have to say, in my experience, those are the patients I'm most likely to regret not doing the tricuspid valve. Dealing with tricuspid regurgitation in the immediate postoperative period, that's discouraging, and usually those are the ones I regret it in. I think the very young patient who has a valve that may be borderline, and you take a look at it and you see there's no mismatch, it looks competent, that one I'm probably going to shy away from.
Well, listen, you've done, your paper was fabulous. Your moderating was even better.
It was good fun.
It was really good fun. Thank you so much.
Thank you so
okay,
much.
Thank you. And thank you for watching. Come back and join us soon.